So good afternoon, everybody. Today we'll discuss the guidelines for urinary tract infections. So can you tell me what is urinary tract infections? Urinary tract. Okay. So we have types of urinary tract infections. So first type of classification is based upon the location of the infection. Okay, that is lower UTI and upper UTI. So lower UTI, that is the infection in the urethra and the bladder. That is, urethra is urethritis and bladder it is cystitis. Whereas upper UTI, infection in the ureters and the kidneys, mainly only kidneys, that is pyelonephritis. Okay, so that is one type of classification that is based upon the location. Second type of classification is based upon the complication. Okay, so it can be classified into different types. That is, first is asymptomatic bacteremia. Second is uncomplicated UTI. Third is complicated UTI. Fourth is catheter-induced UTI and recurrent UTIs. Okay, so basically we have 5 types. That is based upon the complication. First is asymptomatic, complicated, uncomplicated, catheter-induced, and finally recurrent. So coming to asymptomatic, so how can you differentiate? So asymptomatic, in case of women, they should have urine sample collected 2 times. Two samples collected urine, and they should have a colony of about 10 raised to 5 colony forming units per ml. Okay, in 2 samples. Okay, I'm talking about asymptomatic. Okay, this is in case of women. Next, in case of men, a single time voided urine, just a single time voided urine, and that sample should have again 10 to the power 5 colony forming units per ml. And in a patient who is having catheter, so they should, with indwelling catheter, the urine which has been collected, the urine which has been voided, they should have about 10 to the power 2, that is 100 colony forming unit per ml. Okay, then you can tell that they are known to have asymptomatic bacteremia. Next is complicated UTI. Again, uncomplicated UTI. Uncomplicated UTI is of 2 types. That is uncomplicated cystitis and uncomplicated pyelonephritis. Okay, so how can you differentiate between complicated and uncomplicated UTI? So uncomplicated UTI is something which you develop when a patient is healthy. Okay, the symptoms of UTI when a patient is healthy, when they develop, that is called as uncomplicated UTI. Can you tell me the symptoms of UTI? Like frequent symptoms. Burning micturition, dysuria, increased frequency, abdominal pain is not there. Just 3 symptoms. Okay, in the uncomplicated, 3 main symptoms: dysuria, increased frequency, and burning micturition. Okay, so this is the 3 main symptoms of lower urinary tract infections. Okay, and if a healthy person is having this, then that is called as uncomplicated UTI. Okay, again 2 types based upon the location, that is cystitis and pyelonephritis. The most common infection in UTI is cystitis, that is the bladder infection, or pyelonephritis. Okay, that is uncomplicated. Next, coming to complicated UTI, this happens in a patient who is having because of an underlying condition, that is complicated UTI. Uncomplicated is something which happens in a healthy person, whereas complicated UTI is something which happens in a person having an underlying condition. For example, pregnancy, in case of women, pregnancy. In case of people who are having indwelling catheters, again, that is one cause. And next, men who is having obstruction, for example, BPH and all that. Then some patients might have urinary retention because of neurological symptoms. So again, that can be a reason. So they should have an underlying condition. Only then they can develop that infection, UTI. Okay, that is called as complicated UTI. Again, of 2 types: complicated cystitis, complicated pyelonephritis. Okay, so I discussed 3 types. First is asymptomatic, next is uncomplicated, next is complicated. Next comes catheter induced. So catheter induced, okay, how can you confirm it is catheter induced? So first is within you should have to collect 2 samples of urine, and they should have again around 10 raised to 5, again greater than or equal to 10 raised to 5. Okay, if it is just 10 raised to 5, that is asymptomatic. If it is greater than or equal to 10 raised to 5 colony forming units per ml, then it is called as catheter induced. And again, that is one thing. And second symptom is when you develop UTI after removal of a catheter, 48 hours after the removal of catheter, the infection what you develop, again, that is again correlated as catheter-induced UTI. Okay, that is the 4th type. And finally, the 5th type is recurrent infections. So recurrent UTI is something which occurs, the infection, like when you develop UTI within 6 months, 2 times within 6 months and 3 times in a year, that is called as recurrent UTI. Okay, 2 times within 6 months or 3 times within a year, it is called as recurrent UTI. Again, that is of 2 types: relapse and reinfection. Okay, relapse, something which you develop from the same pathogen, same uropathogen, whereas reinfection, something which you develop from a different pathogen. Okay, so you know what is recurrent UTI. Recurrent is something which 2 times within a period of 6 months and 3 times within a period of 1 year. That is recurrent. Again, this is of 2 types: relapse and reinfection. Relapse, same; reinfection, different. So most of the time when we hear reinfection, we think it's the same, but then it's the different uropathogen. And relapse is the same. Okay, so this is the types of UTI. One is based upon the location. Second is based upon the complication. Next, coming to the pathogenesis. So, can you tell me the like who is more prone to develop UTI? Men or women? Female. Okay, women is more prone to develop UTI. So, as you all know, it is because of the urethral. It is because of the urethral length. That is the main reason, and the position. So, that is one thing. So, okay. So, what is the now? How can you differentiate clinically between complicated and uncomplicated UTI? So uncomplicated UTI, you know the symptoms: dysuria, increased burning micturition, and increased frequency. Whereas in complicated UTI, the symptom is they'll have 2 more symptoms extra. That is flank pain here. Okay, this is called as flank pain, and suprapubic pain near the abdomen, lower abdomen, and all. That is called as suprapubic pain. So this is a differentiation between uncomplicated and complicated. Like complicated, they'll have the symptoms which the uncomplicated ones are having, and in addition, they'll have flank pain and suprapubic pain. Okay, so this is the extra add-on addition. So next, coming to the pathogenesis of UTI. So your urethra is getting contaminated because of over-colonization. So there is ascension to the bladder. So in the bladder, again, there is increased colonization. Okay. Then after that, this ascends to the ureters to the kidneys, and it goes and accumulates in a renal parenchyma. So it causes damage. So this can result in acute kidney injury. Okay, so this is a pathogenesis. So it's like down to top. Okay, descending order. Yeah. Okay. So first your urethra is getting infected. Then this ascends to your bladder. Your bladder, there is increased colonization. This increased colonization then travels through your ureters and goes to your kidney and attaches to the renal parenchyma. And because of that, there is kidney injury. So resulting in acute kidney injury. Okay. So the end complication of pyelonephritis is acute kidney injury. Okay. So that is it about the pathogenesis. And now I'll go to the management. Non-pharmacological management. Yeah, and maintain personal hygiene. Then in terms of foods, you can take lots of citrus fruits. Yeah, citrus fruits. Then cranberry fruits, you can cranberry. Okay, so that is better. Then in terms of young females, see to that, like once after your intercourse, you'll have to clean your genital areas. And in case of pregnant women, again, you should maintain healthy hygiene, because pregnant women are known to have increased frequency of urination. So again, healthy hygiene. So that is about non-pharmacological therapy. Next, coming to the pharmacological therapy. So as we all know, any infectious disease is based upon the pathogen which you are getting infected with. So the common pathogens which is again present, E. coli is the common pathogen in UTI. So coming to the management. So first I'll treat with acute uncomplicated UTI. So can you tell me what is acute uncomplicated UTI? Healthy people, healthy individual. Okay, so acute uncomplicated cystitis. The first line treatment is nitrofurantoin 100 mg per oral BD for about 5 days. Nitrofurantoin for uncomplicated cystitis. Uncomplicated cystitis. Okay, so it is nitrofurantoin 100 mg per oral BD for a period of about 5 days. Okay. The next option is trimethoprim plus sulfamethoxazole in a dose of 160 bar 800 mg per oral for BD for about 3 days. Okay. These are the first line therapies. Okay. And next it is phosphomycin 3 gram per oral, just 1 dose. Okay, uncomplicated cystitis. The second line therapy is amoxicillin plus clavulanic acid 625 mg per oral every 8 hours for a period of about 5 to 7 days. Next is ceftriaxone 100 mg per oral BD every 5 days, ciprofloxacin 250 mg per oral BD every 3 days, and levofloxacin 250 to 500 mg per oral every 3 days. Okay, I'll tell again. So acute uncomplicated cystitis, first line therapy is nitrofurantoin 100 mg per oral BD for about 5 days. Trimethoprim plus sulfamethoxazole 160/800 mg BD for 3 days, and fosfomycin 3 grams per oral, 1 dose. Okay, just 1 dose. And second line is amoxicillin plus clavulanic acid 625 mg per oral every 8 hours, 5 to 7 days. Ceftriaxone 100 mg per oral BD every 5 days, ciprofloxacin 250 mg BD for 3 days, and levofloxacin 250 to 500 mg per oral for 3 days. Okay, this is for cystitis. Next, coming to uncomplicated pyelonephritis. Okay, so in outpatients, the first line therapy is ciprofloxacin. This is in outpatients. Okay, uncomplicated pyelonephritis. In outpatients, the first line therapy is ciprofloxacin 500 mg per oral BD for 7 days, and or levofloxacin 750 mg per oral BD for 7 days. Okay, this is a outpatient therapy, outpatient first line agent. Second line agent is trimethoprim plus sulfamethoxazole 160/800 mg BD for 14 days, or ceftriaxone or amoxicillin plus clavulanic acid. That is second line. So first line is cipro plus levo. Okay, in case of pyelonephritis uncomplicated. Next, in case of inpatients. So inpatients again it is ciprofloxacin, ciprox 400 mg IV every 12 hours for a period of 7 days, or levofloxacin 500 mg IV every 24 hours for a period of 7 days. Ciprofloxacin, levofloxacin, ceftriaxone, can you tell me the dose? 1 gram BD for a period of 14 days. And piptas dose, yeah, 4.5 gram. It is like 3.75. If you're giving 3.75, it's every 6 hours. And if you're giving 4.5 grams, it is every 8 hours for a period of around 7 to 14 days. Okay, this is for inpatients. Okay. So this is the treatment option for uncomplicated pyelonephritis. Outpatients, cipros plus outpatients it is ciprofloxacin plus levofloxacin, and inpatients it is ciprofloxacin, levofloxacin, ceftriaxone and piptas. Okay. Next is acute uncomplicated cystitis. Next is acute complicated cystitis. Okay. Acute complicated cystitis or catheter induced UTI without any upper tract infection. Okay, upper urinary tract infection. It is for complicated cystitis. So empirically it is again ciprofloxacin 500 mg BD, levofloxacin 750 mg per oral, cefoperazone plus sulbactam 1.5 to 3 grams IV every 6 hours, ceftriaxone 1 gram IV every 12 hours, and gentamicin or tobramycin 3 to 5 mg per kg IV once. Okay, that is a treatment for complicated cystitis. I'll come again. Ciprofloxacin 500 mg, levofloxacin 750 mg, cefoperazone to sulbactam 1.5 to 3 grams every 6 hours, ceftriaxone 1 gram IV BD, and gentamicin or tobramycin 3 to 5 mg per kg IV once. Okay, once a day. That is empirically. Next, coming to pathogen specific, like once you get to know after the susceptibility test, it is nitrofurantoin, same dose. Nitrofurantoin dose 100 mg BD, trimethoprim to sulfamethoxazole 160/80, and fosfomycin 3 grams per oral, 1 dose. Or you can go with any beta lactamase, that is piptas or something, for a period of about 7 days. That is in case of pathogen specific. And imagine the patient is having ESBL. What is ESBL? beta lactamases or E. coli. Again, the treatment is nitrofurantoin plus fosfomycin, okay, for a period of about 7 days. This is for acute complicated cystitis and catheter-induced UTI. Okay, but they don't have any upper urinary tract infections. That is, no signs of pyelonephritis. Only cystitis. The first line agent is ciprox, ciprofloxacin, levofloxacin, cefoperazone plus sulbactam, ceftriaxone, gentamicin. In case of empirical management, pathogen-specific nitrofurantoin, trimethoprim, fosfomycin. Okay, and in case of ESBL, fosfomycin and nitrofurantoin. Okay. Next, coming to acute complicated pyelonephritis. Acute complicated pyelonephritis plus catheter-induced UTI and urosepsis, all the three, okay? Because acute complicated pyelonephritis is only a complication, right? So this can obviously result in urosepsis, and in addition to that, severe catheter-induced UTI. So the treatment goes like this. For outpatients, it is the same treatment as that of uncomplicated patients. This one, same treatment for outpatients. Ciprofloxacin 500 mg per oral BD or levofloxacin 750 mg per oral BD. In case of outpatients. For inpatients, empirical management is in case of inpatients, okay? This is for complicated pyelonephritis. In case of inpatients, ceftriaxone 1 gram BD. Then it is ceftazidime class. Third generation, okay. Ceftazidime 1.2 grams IV every 8 hours. Cefepime class. Fourth generation. Good. 1 gram IV every 12 hours. Next is Piptas. 4.5 grams IV every 8 hours. Okay. This is for complicated pyelonephritis. Imagine the patient is having urosepsis. So the first line agent, urosepsis, meropenem. Meropenem 1 gram IV every 8 hours. And one more, colistin. Loading dose 3 milliunits followed by 1 million units BD. Okay, so this is the treatment for urosepsis. Okay, meropenem and colistin is reserved for urosepsis, and this is for the inpatient's complicated pyelonephritis. Okay. Next, this is empirical treatment again. Okay, coming to definitive treatment, you can add on trimethoprim plus sulfamethoxazole 160/800, ciprofloxacin 500 mg BD, and levofloxacin 750 mg in case of complicated pyelonephritis. I'm not talking about urosepsis. Okay, in case of complicated pyelonephritis, the definitive therapy is add-on therapy is trimethoprim plus sulfamethoxazole, ciprox, and levo. And in case of urosepsis, it is meropenem and colistin. Okay. Next, coming to UTIs and asymptomatic bacteremia in pregnancy. So, do you think treatment is required in pregnancy?
Yes.
Yes. Okay. So, can you suggest any drug? Like, we have so much, right? What do you think? Ceftriaxone. Okay. Okay. So, the treatment of treatment choice is nitrofurantoin 100 mg per oral BD. Okay. But this can't be used in first trimester and last trimester. First and third trimester. Okay. The reason is hemolysis. The side effect of this drug is hemolysis. If you're given a pregnant woman, fetal hemolysis. So this is avoided, nitrofurantoin. Okay. And amoxicillin plus clavulanic acid 625 mg per oral BD for 3 to 7 days. That is the treatment option. Like if you go with the safest drug, nitrofurantoin can be given, but then if you prefer safest drug, it would be amoxicillin plus clavulanic acid and cefalexin. That is second generation cephalosporin, cefalexin, 500 mg per oral every QID. 500 mg per oral, and we have fosfomycin 3 grams per oral OD can be given once. Again, this is known to cause G6PD deficiency in the fetal, so again it is avoided. And again we can give trimethoprim plus sulfamethoxazole. Can you tell me the trimethoprim plus sulfamethoxazole?